So, moving on, our next presenter is Lyndelle Lee. She's the Nurse Unit Manager from Ward C in Mid-North Coast Local Health District, and she's going to talk to us about the CALM Falls Prevention Initiative. Make sure you...
Good afternoon, everyone, and thank you for the opportunity to present today. My name is Lyndelle Lee, and I'm the Nursing Unit Manager of Ward 1C and the Acute Geriatric Evaluation and Management Unit, known as the AGEM, at Port Macquarie Base Hospital. Today I'd like to share our journey of the CALM Falls Prevention Initiative, a clinical-led, patient-centred approach that has significantly reduced inpatient falls within our acute geriatric setting. This presentation is not only about outcomes, it's about what happens when we make risk visible, involve patients and families as partners, and empower frontline staff to lead practical change in complex clinical environments. Why falls prevention matters in the AGEM. As we know, falls remain one of the most common adverse events affecting hospitalised older adults. In AGEM, our patients frequently present with frailty, delirium, cognitive impairment, polypharmacy, and fluctuating mobility. For these patients, a fall can result in serious injury, extending hospitalisation, loss of confidence, and long-term functional decline. Despite robust assessment processes, we recognised a persistent challenge. Falls risk information existed, but it lived primarily within documentation systems. In a busy multidisciplinary ward, this meant critical information was not always immediately visible or shared in real time across the care team. What we were seeing was a gap between knowing a patient's falls risk and acting that knowledge consistently throughout the day. So identifying the gap. Our AGEM unit is a highly collaborative environment. We have nurses, doctors, allied health clinicians, ward clerks, assistants in nursing students and families all contribute to our care. Yet without a standardised and visual system, falls prevention strategies could become fragmented. One of our registered nurses, Carly Waby, identified that to shift from reactive to proactive falls prevention, we need to rethink how risk information was communicated. The solution needed to be simple. It needed to be intuitive and immediately recognisable. Something that would prompt conversation, shared accountability, and early intervention. From this insight, the CALM Falls Prevention Initiative was developed. So the CALM framework. CALM is built on 4 interconnected pillars that guide everyday clinical practice. C is for connect, establishing rapport with patients and families on admission, involving them in the safety planning and understanding their base mobility and concerns. Being connected means delivering truly individualised care. It means understanding the patient's story, their mobility, their confidence, and their preferences. It ensures that everyone involved in their care, nurses, allied health, medical staff, even our ward clerks, share the same clear understanding of their falls risk. A is for assessed. We complete the falls assessment risk within 8 hours of admission using the OMS falls risk screen, supported by clinical nursing judgment. L is for listen. CALM also requires us to listen. Listen to our patients, listen to our families, and to each other. Listening goes beyond hearing concerns. It's the observation of verbal and non-verbal cues, recognising the confusion, the fatigue, the anxiety, and the overconfidence, and understanding patients' preferences and behaviours, because not everyone is the same. M is for manage. implementing and adjusting risk-appropriate strategies that support safe mobilisation and independence. The strength of CALM lies in its simplicity and adaptability. It provides a shared language for the falls prevention across all disciplines. So our innovation into practice. To operationalise CALM, the team introduced, as you can see above, a colour-coded falls risk poster system inspired by the Australian Fire Danger Rating System. Each poster clearly displays the patient's falls risk level. Red for extreme, orange for high, yellow for moderate, green for low. These posters are placed on the patient's door and they are simple pictorial information displayed that can be circled or ticked. So how the patient mobilises, are they independent, walking with a stick, a four-wheel walker, a pickup frame, forearm support frame, SARA steady. The level of assistance that is required, are they standby assist, 1 assist, 2 assist? And any mechanical aids, such as the falls mat, that may be needed, or when is it needed? For example, at night time. The patient privacy is maintained by displaying only the patient's first name on their door. For patients identified as high or extremely high risk, additional strategies are implemented in the AGM. We increase observation rounds and room placement for those patients are usually closer to our nurses' station, and the use of the falls mat and other mobility aids. Importantly, the posters act as a visual cue for all staff and form a focal point for discussion during bedside handover, safety huddles and multidisciplinary rounds. CALM was trialled over 3 months from September to November in 2024, and due to the positive outcomes and the staff engagement, it has since been embedded into routine practice into the AGM. We now know no different. After our initial trial, we organised and progressed to our colour coding risk to coloured name tags that could be attached to the patient's device when mobilising around the unit for visualisation in real time. This also avoided confusion with which device was theirs, especially when they all gathered in the communal lounge for activities. During the 3-month trial period, AGM recorded 7 falls, compared to 26 falls during the same period the previous year. That's a 73% reduction. While we acknowledge that patient cohorts vary and causation cannot be definitely established, the consistency of staff feedback was noticeable. Staff reported improved situational awareness, clearer communication, and increased confidence in falls risk. Looking at a longer-term trend, the impact becomes even more evident. Over the 5-year period, annual falls reduced from 135 in 2021 to 48 in 2025, following the introduction of CALM. The ongoing downward trend is continuing in 2026. Year to date, for the first third of the year, we have had 8 falls. Beyond patient safety, the initiative has contributed to reduced post-falls investigations, fewer imaging requests, and potential reductions in length of stay, supporting both clinical and operational outcomes. The patient and staff experience. CALM has positively influenced both patient and staff experience. Patients are supported to mobilise more safely and confidently, enabling greater participation in therapy and daily activities. Families are reporting and feeling better informed and more engaged in the care planning of their loved ones. For staff, CALM has fostered a sense of shared responsibility and empowerment. Falls prevention is no longer seen as a task or a checklist, but it's the ongoing collective practice embedded into everyday care. Talking about sustainability, well, CALM is intentionally low cost and it's sustainable. It's laminated, it's wipeable, posters are durable, they're compliant with work health and safety standards and require minimal ongoing resources. With appropriate education and leadership support, this approach is easily transferable to other wards, facilities and patient populations. We are currently sharing our learnings more broadly and exploring opportunities for wider implementation. So the key learnings and future directions of CALM. One of our key learnings is that effective innovation does not need to be complex. Making risk visible, creating a shared language, and empowering the frontline clinicians can lead to meaningful improvements in patient safety. CALM reinforces the value of clinical-led improvement and aligns strongly with patient safety and harm minimisation priorities. So in closing, the CALM Falls Prevention Initiative demonstrates how simple, visible and collaborative approach that the change in behaviours, conversation and outcomes in acute geriatric care. I'd like again to acknowledge Kylie Waby for her leadership and innovation and thank the entire AGM team for their commitment to embedding CALM into everyday practice. And before I leave, I just want to share a quick video that ties together everything mentioned here today. The video was created for our 2025 Excellence Award submission. Thank you for your time and attention.
The CALM initiative was introduced as a 3-month trial in the AGEM unit at Port Macquarie Base Hospital to identify patients at risk of falls during admission and handover. CALM stands for Connect, Assess, Listen and Manage. Connect means staying connected with patient care. Assess involves evaluating falls risk through history, medications, physical ability and environment. Listen focuses on observing and understanding patient needs, including non-verbal cues. Manage coordinates and addresses falls risk to improve patient outcomes. During the trial from September to November 2024, falls in the AGEM unit dropped from 26 the previous year to just 7, a 73% reduction. The success and positive feedback from staff have led to CALM becoming part of daily practice for all patients.
Thank you.
Thanks, Lyndelle. Don't run away. We'll just see if we've got some questions, first of all. Congratulations. That's a dramatic decrease in falls for your ward. That's excellent. Now, does anyone have any questions in the room? Just put your hand up and we'll get a microphone to you. Yes, there's one down the front here.
Amazing work and great presentation, thank you. And I'm sorry if I missed this, but with the signs, what is your process of ensuring that they're maintained in terms of being kept updated? And are there specific disciplines that have certain responsibilities and sort of how has that been rolled out?
So the AGM unit, we have daily physio, OT, and we have a multidisciplinary meeting every week, but bedside handover, it's a point that we look at every day and we're constantly assessing our patients every day anyway. And any change notable, all the staff are really involved that they know to update it. Like, it's really amazing how it's just become embedded into everyday life.
Amazing.
It is good.
Okay, thank you.
Sorry, can we ask one more question? Just
really
with the
quick.
risk assessment side of things, was it just based off the Ontario assessment or did you also include the FRAMP into that?
It led to the FRAMP and the SIMP and all those other tools that we do use, but it did basically just start with the OMS and clinical judgment, and it's working. So we're going to continue with what works.
And just checking from a geriatric perspective, with delirium being quite a big thing in that setting, obviously, like, did your staff change it when there was acute deliriums and that risk was there?
Correct.
Awesome. Thank you.
Fantastic. Thanks, Lyndelle.